Contraception or birth control are methods used to prevent unplanned pregnancies. Contraception methods can be classified into two categories, hormonal and non-hormonal. In this video, we will focus on the non-hormonal methods. There are a number of non-hormonal methods that a woman or man can choose from. They are categorized under natural, barrier, copper intrauterine device, and sterilization. While the others are temporary and reversible methods, sterilization is a permanent and irreversible method. The fertility awareness method is based on identifying a woman's safe time during her menstrual cycle when she's least likely to fall pregnant. This is assessed through recording of menstrual cycles, basal body temperature, and cervical secretions to avoid the window of ovulation. It requires daily attention. The lactational amenorrheic method provides contraception when three conditions are met. 1. Amenorrhea, not having any menstrual periods after delivering a baby. 2. Fully or nearly fully breastfeeding. 3. Less than 6 months postnatal. Another form of birth control should be used when not all of these three conditions are met. Abstinence or withdrawal methods prevent the egg and sperm meeting and therefore fertilization. Withdrawal is less effective due to sperm in pre-ejaculation fluid. This method is free, does not have any side effects, and does not affect fertility. However, it requires high motivation and compliance. Higher failure rates are reported, especially for those with irregular cycles. Barrier contraceptives are physical or chemical methods that prevent the sperm from meeting the egg. The male condom is made out of latex or non-latex for those with allergies. They create a physical barrier to prevent the sperm from meeting the ovum. It has a failure rate of 13% with typical use. The male condom is cheap and widely available, simple to use and dispose of. Reversal to fertility is immediate. In addition, physical barrier contraceptives such as the male or female condoms also reduce transmission of viral and bacterial STIs and pelvic inflammatory disease. If not used properly, the male condom might slip, tear, or break. It can be used with water-based lubricants, but not with oil-based lubricants such as massage oils, baby oil, or petroleum jelly. Those with latex allergies should use latex-free condoms. The copper IUCD is a non-hormonal long-term contraceptive that offers up to 10 years of protection. The current model in Singapore lasts 5 years. The device is administered under aseptic precautions by a trained healthcare professional. It can be inserted anytime in the menstrual cycle as long as there is no risk of pregnancy. Threads connected to the stem project out of the cervical os to facilitate removal. The copper also impedes sperm transport and stops sperm from fertilizing any ovum by inciting phagocytosis of spermatozoa by the macrophages. The IUCD creates an inflammatory response that prevents implantation. The method has a 0.6% failure rate with perfect use and 0.8% typical use. The copper IUD device offers long-term contraception for 5 years, allows immediate return of fertility on removal, is the most effective method of emergency contraception, and is more cost-effective compared to many methods. However, the insertion and removal procedure can only be done by a trained professional, and the insertion process can be uncomfortable. There are some side effects that may occur during and after the insertion procedure. These include the possibility of syncopal episodes, abdominal cramps, and vaginal bleeding. Menstruation may be heavier, longer, and more painful. There is also a risk of pelvic infection, which is higher within the first 20 days of insertion of the IUCD. Uncommon complications include uterine perforation, device expulsion, and missing threads. If threads are missing, the presence and location of the device should be sought using ultrasound scan and/or X-ray. Depending on where the IUCD is found, specialist referral may be needed for removal. Translocated IUCDs should be located with an X-ray and/or pelvic ultrasound scan. In the case of intrauterine pregnancy with the IUCD in situ and threads visible, removal of the device is advised if the woman decides to continue the pregnancy, although there is a higher risk of miscarriage and infection. If the IUCD remains within the uterine cavity, the pregnancy may continue without removal. However, there is a much higher risk of miscarriage, premature labor, and uterine infection. There is also an increased risk of an ectopic pregnancy if pregnancy occurs with an IUCD within the uterine cavity. However, the absolute risk of falling pregnant while using the IUCD is very low. 1 in 2 pregnancies with an IUCD in situ are ectopic pregnancy. Pelvic ultrasound should be performed early. The following absolute and relative contraindications to the use of IUCDs. Sterilization is the permanent surgical method of contraception that includes male vasectomy and female fallopian tube occlusion or partial salpingectomy. Vasectomy works by occlusion or division of the vas deferens to prevent the release of mature spermatozoa into the semen. It is a highly effective contraception method, and the operative technique is simple with a short learning curve and low complication rate. It is performed under local anesthesia and has a low failure rate of 1 in 2,000. After the surgery, contraception or abstinence is still required for the next 3 months until azoospermia is evident on 2 samples in semen analysis. It may take 10 to 15 ejaculates to achieve this. Although vasectomy is safe and has no side effects, it is a permanent method that is irreversible. Short-term side effects: pain, bruising, hematoma, infection. 1. In a small proportion of men, sperm will persist following vasectomy. If sperm is still noted 7 months post-vasectomy, then it will be deemed a failure. 2. Low risk of post-operative testicular, scrotal, penile, or lower abdominal pain that is rarely severe and chronic in some men. The female sterilization method works by mechanical occlusion or resection of the fallopian tubes. This form of contraceptive is highly effective and has a failure rate of 0.5%. For pregnant women, female sterilization can be performed within a few hours or days after normal delivery, at 6 weeks or more after delivery, or concurrently at the time of cesarean delivery or termination of pregnancy. Interval sterilization, that is, sterilization performed 6 weeks or more after delivery, is ideally performed during the proliferative phase of menstrual cycle, or any time if the woman is not pregnant. Sterilization can be performed using the following methods: mini-laparotomy, immediately postpartum, or laparoscopy, 6 or more weeks after delivery. During mini-laparotomy, a small incision is made below the umbilicus and bilateral fallopian tubes are identified, then resected and ligated. The modified Pomerose technique involves resecting a segment of fallopian tube by making a loop and ligating the base with delayed absorbable suture. The cut ends eventually get sealed off and separated after a few weeks. The operation is technically easy and done during the same admission for vaginal delivery. Laparoscopic sterilization is performed by application of silastic rings, Hulker or Filshie clip, or by the electrosurgical method of destroying the fallopian tubes. During application of Filshie clips, a clip-loaded applicator approaches the fallopian tube, grasps it in entire thickness about 2 to 3 centimeters from the cornual end, isthmic portion, and is clamped over the full thickness of the tube on both sides. The female sterilization method is highly effective and is performed as a day surgery procedure. The operation time is expected to be short, and the woman usually recovers quickly from the procedure. The method offers immediate protection and reduced risk of ovarian cancer. Results are immediate without long-term side effects. It does not affect breastfeeding. This method is permanent with a failure rate of 1 in 200. There might be rare but serious risks when it comes to the surgical procedure, including vascular or visceral injury during laparoscopic entry, as well as risks from general anesthetic. Risk of regret is 5%, with 1% requesting reversal. Request for reversal is more common in those under 30 years of age and during pregnancy, including abortion. Thank you for watching this video. This video is presented by Yongloo Lin School of Medicine's Department of Obstetrics and Gynecology. For more videos like this, head on to the National University of Singapore's website.